Dr. Tejaswini is going to present to us on clinical, radiological, and genetic profile of surfactant deficiency disorders from a tertiary care center in Chennai.
Good morning, everyone. I'm Dr. Tejaswini, and my topic is clinical, radiological, and genetic profile of surfactant deficiency disorders from a tertiary care center in Chennai. Surfactant is secreted by type 2 pneumonocytes and made up of phospholipids and proteins, and it is a surface active agent that reduces the surface tension. There are like 4 types of surfactant proteins. While A and D helps in host defense, B and C surfactant proteins reduces the surface tension. Preterm children present with hyaline membrane disease due to qualitative defects of the surfactant, and in surfactant deficiency disorders, it is due to quantitative defects of the surfactant. While surfactant protein B and C are due to defective metabolism of the surfactant, ABCA3 and TTF1 mutations are due to defect in transport of surfactant. Age of onset, it is like very variable, and it can be from birth to adulthood, and SPB can present as neonatal respiratory distress, and it is lethal without lung transplant, while SPC presents more like ILD than neonatal respiratory distress. ABCA3 can present ABCA3 and TTF1 both can present as either respiratory distress syndrome during the neonatal period or ILD. Inheritance, while surfactant protein B and ABCA3 inherited as in recessive fashion, and SPC, TTF1 can be inherited as dominant or sporadic. Like I already said, SBB and severe ABCA deficiency can be lethal, while SPC, TTF, and ABCA3 have variable presentation. So our aim is to describe the clinical, radiological, and genetic profile of the children diagnosed with surfactant deficiency disorders in our center. We did the retrospective description of the children diagnosed over the last 5 years. So this is a tabulated column of all the 10 children and their symptom onset, and there is equal ratio of both males and females, and age age at the presentation, the youngest children is at birth and the oldest is at 12 years. Consanguinity seen in all cases except for one, and there are affected siblings in 3 cases, and one had proven APCA3 mutation in older sibling, while 2 died of unexplained respiratory distress. Neonatal respiratory distress is seen in 3 cases, and symptom onset youngest seen at birth in 3 cases, and while the oldest presented at 9 years, for 9 years the child didn't have any complaints. And all children had, except for one, had resting tachypnea at presentation, and cough was present in all cases except for one at presentation. Failure to thrive is present in all cases as a rule. And pan-distal clubbing is, except for one case, all children had pan-distal clubbing. And loud P2 present in 3 cases. And room air saturation, there were 3 children who are hypoxic at presentation. So most common age of presentation is less than 5 years, and median age of diagnosis is 2.5 years. Oldest child is 9 years, who had symptom onset at 9 years, and youngest child at birth. Coming to radiological and genetic profile, all children had reticular and nodular opacities, and HRCT findings show diffuse GGO and septal thickening in few cases, and only one child has central bronchiectasis. And echo showed pulmonary hypertension in 3 cases. It was severe in 1 case and mild to moderate in 2 cases. And all children except for one proved to have ABCA3 mutation, inherited as autosomal recessive homozygous. And only one child is compound heterozygous, had 2 mutations. And surfactant C mutation protein C mutation was seen in 1 child. And it is inherited heterozygously, and it is autosomal dominant. So all of the children had variable respiratory symptoms throughout infancy, except for one child developed symptoms at 9 years of age. And all children with ABCA3 mutation had consanguineous parentage. Child with SPC had non-related parents. All children except one presented to us with established ILD. The only child which did not have established ILD is the child who diagnosed at neonatal age itself. And children with ABCA3 had novel homozygous mutation in exon 8, and one child had heterozygous SPC mutation. And this mutation is accounted for 25 to 35% of cases identified to date. So it should be considered as one of the differential diagnoses of interstitial lung disease in children less than 2 years. Genetic analysis is necessary for definitive diagnosis to eliminate the need for lung biopsy in stable patients. Lung biopsy should be obtained if genetic report is equivocal in patients with rapidly progressive disease to look for compatible histological patterns. And outcomes in ABCA3 mutations are variable, ranging from irreversible respiratory failure in early infancy to chronic static or progressive interstitial lung disease, and with many patients surviving well into second decade without lung transplantation. In our cohort, ABCA3 mutation responded dramatically to corticosteroids given as pulse methylprednisolone and hydroxychloroquine and azithromycin, and treatment is based on available case reports. All children with ABCA3 mutations are doing well with medical therapy, and the child with SPC mutation had developed severe pulmonary hypertension and showing progressive worsening of the symptoms. Thank you.
Thank you. So one of the questions I had about this is there any other relevance in the literature of how much SPB or TTF1 mutation deficits are there in the Indian population? Do you have any literature around that? No. So the other question I had was, what is the turnaround time for genetic diagnosis from the point of sending the sample to getting the result?
It's around 40 days.
40 days.
Okay.
Yeah, thanks for that. One question I had is, so you were talking about the management with methylprednisolone, et cetera, Did you use any non-invasive ventilation at all in these babies as treatment, or?
All the children who had hypoxia improved with steroids, sir. With minimal oxygen, they were presented when treated with minimal oxygen. After steroids, they actually improved. Discharged on room air.
So none of them actually needed to go on to any
sir.
other form of ventilatory support?
No, sir.
Here you have used azithromycin. Is it an immunomodulator?
Yes, sir.
So your treatment consisted of steroids, azithromycin, and hydroxychloroquine? No. The treatment was azithromycin, hydroxychloroquine, and steroids in all the patients?
Yes, sir.
Yeah.
Yes.
Okay. Thank you.